Welcome to the National Academy of Medicine convening on the use of health technology to reduce burnout. I'm Tait Shanafelt, Chief Wellness Officer and Associate Dean at Stanford Medicine, and I'd like to welcome you on behalf of my co-chairs, Dr. Christine Castle and Dr. Jeffrey Gold. Today's session is part of the broader National Academy of Medicine Action Collaborative on Clinician Wellbeing and Resilience. The goals of the Action Collaborative are to raise the visibility of clinician burnout, depression, moral injury, and suicide, to improve understanding of the challenges to clinician well-being, and to advance evidence-based multidisciplinary solutions that will improve patient care by caring for the caregiver. If we can move to the next slide, this slide summarizes the efforts of the Action Collaborative over the last 5 years. I know many of you are familiar with the consensus study released by the National Academy in late 2019, entitled Taking Action Against Clinician Burnout, a Systems Approach to Professional Wellbeing. The current phase of the National Academy effort involves translating the recommendations of that report, along with subsequent insights gleaned during the COVID-19 pandemic, to devise a national plan to improve the well-being of the U.S. healthcare workforce. This work by the National Academy is being advanced by 3 working groups. And if we can go to the next slide, the 3 working groups are listed here. They focus on mobilizing national stakeholders, implementing tools to improve clinician well-being, and then navigating and as well as mitigating the negative impacts of COVID-19 on clinician well-being. If we can move to the next slide, today's session is part of the efforts of the Mobilizing National Stakeholders Working Group, and focuses on the potential for health technology to be part of the solution to this problem. The insights and perspectives shared in today's session will be incorporated into dimensions of the national plan dealing with technology solutions and reducing administrative burden. Our goals for today are listed here on this slide, and will be the topics we cover over the rest of our time together today. With that, let's jump right in to our opening keynote. Please input your questions as they come up in the chat, and feel free to engage with each other during the sessions. Today, we have the great pleasure to hear from Dr. David Rhew, the Global Chief Medical Officer and Vice President for Healthcare at Microsoft. David is also adjunct professor at Stanford University. His complete bio can be found in the previously circulated meeting materials. David has both a broad view as well as deep expertise into the potential role of the ability of technology to bring innovation and reduce clinician work burden. David, thank you for being here today.
Okay, wonderful. Well, first of all, thank you for hosting this session. It's such an important topic. I remember in 1990, when I first started seeing patients, I used to go on to the wards, I would look through the carousels, pull a chart out, scribble down a few notes, write some orders, look for the next chart. And then the electronic health record era came about. And a lot of what I ended up having to do was now transition from this other way of doing things to an electronic version. And what we oftentimes found was that there were some things that were certainly a lot better. It was my handwriting was a lot better. My notes were a lot clearer. Gave me a lot of chance to think through some of the things that I had previously scribbled down. But just to do one note or to enter into an order, I might have to go through 4 or 5 screens, and it would add anywhere between 10 to 20 seconds every little task, and it just added up. And by the end of the day, I just didn't have enough time to be able to do this between patients, and I'd have to push this off to the end of the day. And I remember starting to think about then all the things that within an organization, we all focus on quality, safety, and all the different measures that started coming out, and then all the alerts that started coming onto my desktop, and then the inbox and all the different things I started managing. And it became pretty overwhelming. Then the pandemic hit. And of course, when you think about the frontline workers, the nurses, the physicians, the pharmacists, we were not only handling all the existing administrative tasks, but then we were handling the overload of patients and doing the triage. And it was pretty overwhelming. And at this point, I think we know we're in a crisis. If we go to the first slide, I want to just share some statistics. I'm not going to go through obviously all of these, but I'm just going to highlight a few things. More than half of clinicians, and I'm talking nurses on the front line, physicians on the front line, pharmacists, et cetera, they're burned out. And in fact, many are leaving the practice. This is a major issue. We were talking previously about physician and nurse shortages and primary care. It is far worse now than it ever was before. And that is why this is not just a topic that we should sort of try to explore, but we need to act urgently and try to think about ways that we can address this, because this has a ripple effect across the entire healthcare system. When you don't have enough physicians, you don't have enough nurses taking care of patients, especially if they're critically ill. I don't need to share all the details, but we all know this is something that we have to urgently fix. As we move on to the next slide, I want to talk a little bit about what we do know from talking to many organizations around the world, and in particular, frontline workers. In fact, we did a survey where we surveyed frontline workers and validated almost all those statistics that you saw there. But we also learned a lot about what people were doing and what seemed to be working in different areas. And I'm going to put it into 6 categories. Certainly the things I just talked about were the administrative, the work overloads, and how today the models of care seem to be very much not designed around efficiency. And we need to start rethinking about that. But we also saw significant number of individuals feel underappreciated. And I'll just give a simple example. Certainly when you think about how nurses were having a shortage, they started bringing in other nurses that were getting paid a lot more than the existing nurses. I mean, that immediately gives the sense of, wow, am I really a valued employee because you're paying somebody else? And in fact, maybe I should do that. I should just go out and find another, gig where I'm going to go travel. And so recognition, rewards, just making sure people know above and beyond, the celebrations we have. I think that was clearly a key message. We also saw that a lot of this was around working directly with communities. And what we saw with the pandemic, it wasn't just about what was happening in a hospital or clinic, but it was happening in society. And we found that, what people's perceptions were, we had to figure out a way to somehow address those, because the pandemic was an interrelated issue, that it wasn't just about, healthcare. It was about perception. It was about cultural needs and understanding all the issues that came up. And this tied into the whole issue around equity and fairness and really trying to understand. And we have seen that with the pandemic, in particular across the board, certain individuals and certain groups were affected more than others. Frontline workers, but even, women that are perhaps maybe taking care of their children. It exacerbated this scenario. Individuals in underserved areas with less resources, there's a significant number of equity issues. And at the end of the day, we have to think about the individual and their well-being. And a lot of that has to do with just the fact that, we are all struggling psychologically, mentally with these challenges. And if we don't think about that, now, I could probably go on and on, but I was only asked to give about 10 to 15 minutes on this. So I'm just going to focus on the technology elements that we know today that will address the first 2 categories, the work overload and the new models of care. If you move on to the next slide, I want to just ground ourselves into just a couple of different areas that we are seeing. There are a lot of factors, but the things that we see again and again with regards to nurses and physicians in particular: overworked, the environment is very stressful, there's not enough people. In fact, when one nurse leaves, it's hard to find another one. Everyone else has to pick up that load. So it's now even more work on top of that. And then EHR workload. So these are the categories. And I want to talk about some technologies that can help. Let's move on to the next slide. The first technology is something called ambient clinical intelligence. And this is an area where we have seen a tremendous explosion in terms of our capabilities, because of the fact that we are developing artificial intelligence that can understand words, map it to context, and ultimately change the way that clinical workflow is designed. So in ambient clinical intelligence, a clinician is talking to a patient. That conversation is converted from voice to text. The computer understands who's talking when. And then on the back end, those words are converted or translated on the back end to terminologies, medical terminologies, that are then organized into concepts, which then can be organized into a clinical progress note, and then with a push of a button, integrated into the electronic health record. This has already been shown to decrease the amount of time it takes a clinician to enter or document into an EHR by anywhere between 50 to 80%. I want to show a quick video that will highlight the impact of this.
You don't become a doctor to bill. You become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor, like it used to be.
There's a certain business requirement for a structured note and careful documentation, precise diagnoses, and carefully backed up coding for the business practice of medicine. But ultimately, it's about the patient's story.
If you look at the promise of meaningful use and all the reasons we got into a digital health record, it really was to take better care of the patient. Unfortunately, sometimes we've done that through a barrier, meaning we added a keyboard, we added a computer. And I think that's a key part of why physicians are frustrated.
And I mean, you notice as a patient, you notice that your physician is typing and talking and, yeah, okay, yeah.
Now we can go into the background and just capture all the information you needed, but also maybe more importantly, capture something that was missed. That missed was the patient's story.
There's a device on the wall and it's listening to your conversation and it's able to discriminate between a patient and a physician and a family member and is able to generate a progress note and a patient encounter based on your conversation.
What it has enabled is that I can pay attention to what you are saying, because it is very important for me to have the empathy and you to feel as a patient that you are telling somebody who actually cares about you.
Hey Dragon, start my standard order set for arthritis pain.
The idea of a computer that can listen like in Star Trek and just hear what's going on and make sense of it and slip into the background and listen, but only interject when necessary, that was for a long time a fantasy.
I would say before, in a typical week, I would probably spend 6 to 8 hours documenting, just simply dictating and signing notes. I bet that my time has been cut into half, if not thirds, because of Nuance now.
It takes the hands-on time that the provider has to spend with the computer and puts that time back with the patient.
It really takes a lot of that manual work out of the patient encounter and just allows it to happen kind of naturally.
Ambient puts a listening device in the room quietly, securely, privately, and allows the two people in the room to really have a very intimate discussion on very private things. Knowing that the necessary recording of that for the business of medicine and healthcare can go on in the background, but letting that personal connection continue. And that's the reason I think almost all of us went into healthcare. It's to be able to be there for people, to express caring, to express empathy, and to connect as human beings.
So this technology can be done in a clinic. It could be done with a physician. It could be done with a nurse in patient encounter. It could be done on so many different scenarios. It could be done virtually. So amazing opportunity for us to take advantage of this type of technology, which is available today. Let's move on to the next slide. I want to talk about another issue, and I alluded to this earlier. It's not just about that encounter, but it's about all of the things that we do in follow-up that oftentimes relate to that encounter or precede that encounter. When we think about the InBasket and specifically the EHR InBasket and trying to find ways that we can sort through it, it's very challenging, very time consuming. What we have thought of, if you ever tried to do a jigsaw puzzle and you try to organize and do things quickly, it's easier when you can sort things out. And these are like the right color, these are the right shape, these are the corner pieces and things like that. It allows you to be able to move very quickly. And the same thing can be said with regards to EHR InBaskets. There's a good number of those that could actually probably be allocated or reserved to different areas. that could be then triaged to other individuals on the team to take care of. Maybe it's a med refill, maybe it's a question about a diagnosis or something of that sort. That requires us to apply some human or computer that could interpret that. Traditionally, it's been human, but now with natural language processing that understands the context and understands the clinical terminologies, we can then understand where it can go in sort of that triage process, put it leveraging FHIR and the EHR so that the individuals follow up on it, make sure that we have translation. Sometimes these come in different languages, so that would be applied on top of it, and then automate this whole process through the communication services. It could be through a call center agent. It could be directly through a Teams channel or a mobile channel. So these are the things that we have now seen today that are possible, and we have organizations now that are automating this process. And the results are fantastic. It can result in a reduction about 95% of the in-basket for what the clinician actually has to address, and the rest of the 95% are allocated to the team members. Let's move on to the next slide. Want to also talk about artificial intelligence being applied to different ways that we look at images and things of that sort. Oftentimes when we look at images, we're looking for one aspect. I rule out pneumothorax, or rule out a pneumonia or infiltrate, rule out a pleural effusion. You look at that, and then the radiologist looks for everything though. They're like, oh, by the way, did you know that this person also has a nodule? Or perhaps there's something there that's worrisome. The bones look a little, have you thought about, osteoporosis? Oftentimes we're like, yes, we'll get to that. And we never do. 5% of the time, there's some kind of a finding that requires a follow-up. And what we've realized is that the clinicians, you add it on top of the work, one, they rarely do it. And two, it's just another thing for them to follow up on. Let's move on to the next slide. What we have now seen is that we can then start thinking about how we change the workflows. Traditionally, it's based on the physician doing all the things. So if I think about screening for cancer, doing colonoscopies and mammographies, you see me in my clinic, I'll identify that you're eligible and maybe get an alert that says that, and then schedule for that. You may have gotten an email reminder or a text saying, hey, you're eligible, talk to your physician, or perhaps get scheduled for this. What we oftentimes find is that is a very inefficient process, and it misses a lot of folks. So working with one of our partners, we found that there were a good number of people that got those emails and texts, but didn't follow up on it, or didn't follow up on it even after they visited the clinician. And that was a large number of individuals. So what we decided to do was, rather than it being all on the physician's plate, let's run a campaign. Let's have the entire team empowered so that they can go out and address this. And this was run through the call center, the CRM system. It was empowered, where we were looking to address the social determinants of health issues and all the other factors. And we saw dramatic results. And what happens is, when you start thinking about how you can take things off of the clinician's plates and allowing the rest of the care team to be able to apply this in their workflows through concerted efforts where they're empowered to be able to deliver on it, you can do some amazing things. Let's move on to the next slide. I want to talk about now another aspect, and then I'll open it up for questions. And this is about the fact that even though we have a lot of clinicians that are getting burned out and they're leaving, it's creating an intense pressure on those that are left, but it's also worsening care. And we have seen this again and again, especially in the high acuity areas like ICUs, when you don't have enough physicians, you don't have enough nurses, and maybe the nurses that come in or the physicians that come in that are filling the spots are not trained or as experienced in those areas. This is something that we also need to pay attention to. So how do you reskill or provide that level of expertise to individuals that may be there that oftentimes may not have that prior ability? If you move on to the next slide, I want to share with you an experience that we had working with the National Health Services as they started looking at how they can increase the skill sets in these areas. So if we could go to the next slide, you can run the video.
The concern was that we were going to have mass casualties with thousands of people dying, and that the hospital was going to be overrun. And it was immediately obvious that we were not protected, we didn't have enough PPE, and so there was a lot of fear that actually we were all going to get really sick. And then in the second week of March, that's exactly what happened. We lost a third of our team in a week. I was sat there at the beginning of the COVID pandemic, and I counted 29 people in a close proximity in a single trauma call. And I was thinking, well, if this is how we're going to run the next few weeks, a lot of people are going to get sick, and we have to change this really dramatically. The simple concept was, look, we're going to create completely virtual ward rounds. Rather than sending 4 people, we're going to send 1 doctor in. We very quickly started working with the headsets to identify some use cases. So when you place the headset on your head, what the user will see is a virtual screen or a mixed reality screen, which they can position into any real space in the room that they're standing in. And on that screen at the moment will be the face of one of their colleagues who will be interacting with that user through a webcam based on a desktop. We can call other experts that we might want to call into that clinical scenario. And we can also pull up images and content. So we can look at electronic healthcare record data or x-rays or images. And what it means is that you have all the information, all the specialist care that you need at the patient's bedside, there and then. And it's all in one headset. When this crisis hit, it became apparent that the NHS had to work in a different way, and through really high-level strategic kind of digital infrastructure projects, Teams was just nationally adopted by the NHS. Teams really is now, I would say, an essential tool. We could not run our organisation pretty much without it. The fact that their staff are safe, their ward rounds are really efficient, and that they can communicate more effectively with their staff. COVID-19 will change everything forever in terms of the way we work and how we work. In terms of mixed reality, HoloLens 2 really is the only viable product that we have in the space. And I can see a point where these sorts of tools will be the norm, where you will go on a ward round, or you will go into a clinic, or you will go into an environment that might be high risk, that might be challenging, or where you might need specific capabilities of these sorts of technologies, and it will be there, and you'll just use it, and it won't be a novelty. What I'm absolutely convinced of is that we are just at the very beginning of a very long and exciting journey. And I think what's been very important about COVID is actually it's just given us a real shot in the arm and a huge step change in our perception of these technologies and what value they might bring.
If we move on to the next slide, I want to share. So the
concern was
what was really interesting is that they continued to expand beyond the ICUs, and they started looking at vulnerable populations in nursing homes. And also, very similarly, now there weren't enough staff in the nursing homes, but they provided them with a headset that gave a 360-degree view to the GPs in the back end, so they could actually do virtual rounding into the nursing homes. And more than just simply see the patient, but they could see the IV if it was in place. They could see the drips. They could see the machines. If the rug was perhaps a fall risk, you name it. So extraordinary opportunity to start thinking about how we expand care. Let's move on to the last slide. And this is really just a summary slide. Just wanted to recap kind of the different things we talked about. EHR documentation, a major issue. We're starting to see ambient clinical intelligence being utilized as a means to address that. The inbox automation, it involves a lot of different tools, not just the AI ML for the text analytics, but also the language translation. There's a back-end process of how the data needs to be managed and triaged, leveraging standards like FHIR. We need to start thinking about how we redesign our processes so it's not all on the physician and the nurse, but it's the entire team that is taking care of that. That requires us to apply front-end technologies and back-end communication tools. And it allows us to be able to also start thinking about how we can reimagine care, specifically leveraging virtual tools that empower individuals to be having the expertise behind them in a virtual background. So thank you very much. I will then, I guess, I'm not sure if we have time for questions, or what are your thoughts here?
David, I think we will just have folks drop questions in the chat, and if there are ones you think are key, maybe you can just make some response there, because we actually didn't have a Q&A break here. So we do want folks to put questions in the chat. There will be some time later in the session for discussion, but I think here we're kind of moving right on to the next phase of the session. So, but David, I think, thank you so much. Really incredibly insightful, both perspective on where we're going, and I think some very practical, already in the clinic examples that can give people tremendous hope that there is maybe better things ahead for us where technology will really help relieve some of this work burden, as you've noted. And so I think this is a really fantastic foundation for the remainder of our session today.